Sir, please start the session.
Good morning, good afternoon, and good evening to all of you. At the outset, my sincere thanks on behalf of APSS and the APSS Education Committee, myself and the Education Committee Chair, Online Committee Chair Niraj, for all of you for joining this webinar on a Sunday. My sincere thanks to all the faculty and all the delegates who have joined the program. Niraj has curated a very good program on the current state of affairs of cervical spine surgery, including what is current, what is recent, and what will be the future. I would hand it over to Niraj for the further proceedings. Over to you, Niraj.
Thank you, Ajoy, sir. It's actually my privilege to moderate this galaxy of stars who are present today on behalf of APSS. I guess everybody who has gathered today are probably, you can say, who's who in cervical spine surgery in Asia Pacific region. So without wasting much time, let me first invite our first speaker, Dr. Ajoy Shetty. Dr. Shetty doesn't require an introduction. He has been leader in spine field, probably in one of the largest country of the world, by population in India. So he represents a large country. He has been mentor, teacher to so many students. And he's going to talk today on advanced imaging in cervical myelopathy. Dr. Ajoy, over to you. Dr. Ajoy, your voice is muted.
Sorry, my talk is on degenerative cervical myelopathy, the advanced imaging. Degenerative cervical myelopathy, as you are aware, is a clinical syndrome characterized by cervical cord dysfunction resulting from cervical spondylotic myelopathy, OPLL and OLF. As you are aware, there are three important factors in the pathophysiology: the static factors, the dynamic factors, and the spinal cord ischemia, which is the eventual outcome of these two factors. The MRI and CT scan, which we usually do, will provide us the detail about the macrostructural anatomy, which will help us to diagnose, identify, plan, and prognosticate. And studies have shown that the MRI morphometric, in terms of compression ratio, the maximum canal compromise, and the transverse area of the spinal cord, has got a role to play with regards to the outcome. It has also been shown by various studies, including ours, wherein the presence of a cord signal change, a hypointense in T1 and hyperintense in T2, has got a worse prognosis. Also, the quality and the longitudinal extent of the T2 signal change is also important in prognosticating this particular group of patients. However, when you have a case scenario where an individual has got a minimal amount of symptoms, minimal amount of compression, we may have to assess the dynamic factors. And we also know that the disco-ligamentous complex can also fail. There is a buckling of the ligamentum flavum, which can happen when the individual is sitting, moving, doing a flexion extension movement. For this, we usually have been using dynamic imaging in the form of flexion extension radiographs and MRI in flexion and extension. There have been recent advances in the use of sign MRI, that is the MRI which can be done showing motion, and also cine radiography, which will give us a better idea about instability that is happening and the amount of compression that can be demonstrated in flexion as against to an extension. Looking beyond flexion and extension, now studies are looking at whether there is a role for an axial load. That means when you are sitting and standing, whether the mechanism that is happening over the spinal cord could be different. This is a study done by Dr. Naresh, wherein he looked at the dynamic load-bearing MRI when the individual is sitting, then with flexion, and then with extension. And as you can see in this picture, definitely there is a significant compression that tends to happen with the buckling of the ligamentum flavum, and also a slight increase in the disc bulge as against to supine to sitting. In both these radiographs, it is in MRI pictures, it is well depicted. But these two will give us an idea about the static and the dynamic factors. But what we would also like to know about the microstructural integrity in terms of spinal cord ischemia. The T2 signal change or the hypo and the hyperintensity in T2 and T1 gives us some idea, but it doesn't give us the overall microstructural integrity. That's where the role of advanced imaging comes. Advanced imaging provides quantitative biomarkers of cord health, the structural and the metabolic data, and the functional connectivity. This picture, which is taken from an article by Khan et al., gives us the overall view as to what is happening in imaging in cervical myelopathy. The first one in the center, what you are seeing gives us the macrostructural anatomy. That is the T1 and T2 images, what we see in our usual MRI. On the left is the microstructural anatomy, what we can see by DTI and the MRS. On the right is the functional imaging, which gives us by using functional MRI. I'm going to speak about two of the techniques what we have been used to, DTI and the MRS. Diffusion tensor imaging measures the diffusion of the water molecules in the tissue and the integrity of the white matter tract, that is the axons. We know that these axons has got a myelin sheet, and therefore usually diffusion happens in a longitudinal direction. Therefore, understandably, the diffusion will be more in the longitudinally, that means the FA will be high, whereas the ADC or the apparent diffusion across will be very less, therefore the ADC will become less. But whenever there is a disruption of the myelin sheet and whenever there is a dysfunction of the spinal cord, the FA decreases, that means the directional flow decreases, and the ADC, that is the flow outwards, will increase, and therefore that's how we will know that the cord is dysfunctional. We can also do tactography to see whether some of the tracts are dysfunctional. And this we have shown in multiple studies that patients with myelopathy, that the cord functions varies, the FA tends to decrease, whereas the ADC tends to increase. And this value change will be more based upon the severity of myelopathy based on the MGO score. And hence we will be, it is able to prognosticate also to some extent. And studies have shown that DTI may be sensitive enough to indicate a post-operative neurological recovery. There are various trends. I mean, you can make out microstructural damage, column-specific degeneration, especially with the current generation 3 Tesla MRI. The FA reduction correlates with the myelopathic severity, and it can also predict post-operative improvement. But however, there are problems with DTI. I mean, basically, the motion artifact is one of the very important thing, and to standardization across various machines. And we also have one more scenario. I mean, especially with the current scenario of aging population, and our need also to get more and more MRI. We are seeing patients, we have got a significant compression on the MRI. They might come to you for a back pain or a simple neck pain, no myelopathic signs. You see a significant amount of compression, but they do not have any classical myelopathic signs. What to do with this particular group of patients, especially when the severity of compression is significantly more? Based on the classification of MGO, we can classify the severity as mild, moderate, and severe. But we should also remember there is what is called as a clinically silent CSM, which can be classified into pre-myelopathic and non-myelopathic. Pre-myelopathic, they do not have symptoms or signs, but they show cord compression. Whereas non-myelopathic, they don't have symptoms. They will have some soft signs, but MRI shows cord compression. Why it is important for us? Because the prevalence as the age advances is about 24%. And studies has shown that 23% of them can progress to pre-myelopathic stage or myelopathic stage at 3 years follow. And therefore, it's important for us to know who can progress. What are the symptoms they can develop when they are progressing? Studies by Bednarik, a neurologist from Europe, has shown that he has studied this group of patients over 2 decades. People who are likely to progress are one who has got onset of radiculopathy, electrophysiological abnormalities, if they develop MRI hypersensitivity, and whenever there is a significant compression of less than 10 millimeters of the AP canal diameter and a compression ratio of less than 50%. But however, does advanced imaging help? I'm going to speak about MRS. MRS is nothing but a metabolic fingerprint. We can non-invasively probe the biochemical status of the tissue. You can use it in the disc, you can use it in the spinal cord. And you can look at whether there is a gliosis, axonal neuronal loss, or demyelination that is happening in the spinal cord. How do you look at? We look at the metabolites. See, normally there are various metabolites in the neuronal tissue. N-acetyl aspartate is a neuronal marker. It is the normal functioning of the neurons. Therefore, whenever the N-acetyl aspartate tend to decrease, that means the neurons are not functioning well. On the other hand, choline is a membrane marker. Whenever the choline tend to increase, that means there is a degradation of the neuronal tissue, and that means that dysfunction is likely to happen. Similarly, we have creatinine. Lactate, as you know, is an anaerobic metabolism indicator, myoinositol, and glutamate. And this, when you place an MRS with the region of interest, it is a MRI technique. We don't have to do anything. We just have to select the region of interest. And by water suppression techniques, you get a waveform which has got a frequency based on the signal intensity. And we just have to read it. You get a waveform, something like this. And you have to, it also gives you what it is exactly. And you read it to know whether it's the normal value, whether they are abnormal, and how they are changing based upon the pathology the spinal cord is getting. We looked into this group of patients, and we found that as the severity of the stenosis increases, the MRS also changes. The compression ratio becomes more, the MRS also changes. As you can see, the MRS metabolites, the good metabolite, the NNA, progressively decreases as it goes from normal to severe compression. On the other hand, the other metabolites, which are indicative of a destructive phase, are the neuronal lysis markers. You can make out they are progressively increasing based upon the severity of myelopathy. And these studies have shown, and our study has shown, that there is a significant correlation on MRS metabolite concentration with the outcome, similar to that of DTI, and slightly better with against to DTI when we are looking at patients between normal volunteers and mild myelopathy. What does it show? Whenever there is a suspicion, when somebody presents to us with severe compression, probably with mild signs, sometimes with neck pain or sometimes with early radiculopathy, MRS can help us to identify that who are the patient where the cord dysfunction is already happening at the microstructural level, and probably help us to counsel that as to when to intervene. And this is how it will come. The images will come like this. This is the normal. As you can see, the waveform, you can measure it, and you know which are the molecules or metabolites you are going to look at. And what happens whenever there is a compression, there is a difference of waveform. Our study has shown that MRS and DTI parameters correlate to the severity of myelopathy. MRS metabolite ratios are good enough to predict early cervical spondylotic myelopathy. And this is what we have published in the Spine Journal. And we also looked at other aspect of it. It's not only the metabolic changes seen in patients are different, are higher than in patients without cord signal changes, but we also wanted to look at whether the same group of patients, when we followed them at 1 year, whether the MRS metabolites also correlates with the recovery pattern. And this is what you can look at. We divided the patient based upon the recovery pattern into good recovery and poor recovery. And as you can see, these markers, the CHO, CR, and MINA markers, are correlated with the recovery patterns. With individuals with good recovery has got a better score as against to patients with a poor recovery. Therefore, patients with higher NA and creatinine ratio has got a better recovery, and those with a very low has got a limited improvement. and therefore it also guides treatment decision and patient counseling. But as any new MRI techniques like DTI, MRS, and other new techniques, there are technical challenges. They are very small area of interest. You have to place it very accurately within the spinal cord. You should not cross over to the outside or to the vertebral body. Therefore, there are a lot of motion artifacts that are relatively lesser when compared to DTI, but still they are susceptible to magnetic susceptibility. There are standardization issues, and I think that it will take much more time for us to be sure that to use it as a day-to-day practice. But innovations and future developments are likely to come with hardware techniques, software development, and probably multimodal imaging with integration of DTI, MRS, functional MRI, and AI is probably the future where you can predict. When we do an imaging, we will be able to predict who is likely to improve, who is not likely to improve, what is the prognosis, everything can be done. To summarize, conventional MRI remains the workhorse for diagnosing and evaluating CSM. However, advanced imaging modalities adds a valuable layer of information on the cord microstructure and metabolic state, especially when there is a doubt in an individual when there is a significant compression, whether to proceed with a surgical intervention or not, or whether to observe. It also identifies early cellular changes in the cord, and it may guide early interventions. And most importantly, it may be able to predict to some extent the prognostication as to who will improve or who won't improve. Thank you.
Thank you, Dr. Ajoy. That was a wonderful talk on the newer modalities. I guess we have 2 to 3 minutes of discussion. So if any faculties have any questions, please feel free to ask. Delegates who are watching this webinar on OrthoTV on YouTube, please post your questions into chat box and we will reply to that. Before we go to Professor Kawaguchi for his question, let me begin with asking Dr. Ajoy, how do you use this MRS and DTI in counseling your patient in your day-to-day practice?
Actually, we do not use it in a day-to-day practice still yet. But however, when we have a doubt, like no, this is a part of the study protocol. But in patients who has got significant compression and whether to operate or not, they have started radiculopathy, as shown by the article by Bednarek. Patients who have started developing radiculopathy in a patient with severe compression, that means to say that there is a cord dysfunction that is happening, and over a period of within 12 months, most of them likely will develop myelopathic signs. Therefore, in these patients, we have found it useful for us to counsel that your MRS values are okay, we can observe you. There is an alteration in the MRS value. Probably you will need a surgery, but it helps us to counsel. I mean, we are not going to operate, but it helps us to counsel.
So, in continuation with that, you presented that there is a clinical correlation between severity of myelopathy and our DTI and MRS scores. So, is there any direct correlation with the MJOS score and all this spectroscopy or tensor imagings?
Yeah, actually, higher the severity of the myelopathy, the higher the
but
changes in the values.
No grading, no correlation of grading systems so far.
I didn't get your question exactly.
So, say this kind of tensor imaging would predict that your patient would be having a myelopathy of say MJOA 14, MJOA 13, MJOA 12, something like that.
We haven't looked at
no
that.
grading. No
we
grading.
have seen them clinically diagnose it and then send for MRA.
Okay.
Therefore, you already know.
Okay.
Clinically, we correlate and then with not the reverse way.
Okay.
So far, it should
Professor
be possible.
Kawaguchi?
Yeah, thank you very much, Ajoy. It is very interesting topic of MRI. So I'd like to ask you about the reproducibility of this data using MRS metabolites. So I think the area is very important for the damage of the spinal cord. So the area is fixed. You should fix the area of the interest.
Yes.
So if the area is a bit different, the data might be different. So I'm asking about the reproducibility of this data
See, the thing is that, as I mentioned, is you have to be very, very particular about where you place your voxel. I mean, usually now we know that the changes that happen in the spinal cord not only happens at the level of compression, it also happens proximally and distally. That's why when you do a MRS data, the voxel is placed behind the level of C2, where the area of the canal is relatively more. And the metabolic changes, studies have shown that what changes at C4-5 is also reflected in changes at C2. Therefore, the voxel is usually placed at the level of C2.
I see.
You
I see.
have
Okay,
tried placing at C6. It may be possible in 60% of the cases, but if there is no space, when there is a significant compression, we will not be able to place at the level of the apex.
Is it possible to get the data using the normal MRI, 3 Tesla, or we are using the 3 Tesla MRI? So is this
We are
possible?
using a 3 Tesla MRI. We
Thank you
haven't,
very
because
much.
it's a software that has been associated with the 3 Tesla MRI. I'm sure it could be available in other MRI, but the 3 Tesla MRI, the chances of the mistakes or MRI related issues are relatively lower.
Thank
It
you
is
very
more
much.
standardized to a 3 Tesla MRI rather than 1.5 Tesla MRI.
I
This is
really enjoy.
software developed by the company.
So let's go to the next topic. Now we are coming on to how to study the cervical alignments. Once we have diagnosed that cervical spine has a problem, what is the impact of perioperative sagittal alignment on our surgical decision making? Our next speaker is renowned spine surgeon from Singapore, Dr. Reuben Soh. I guess he is another leader in deformity surgeries of spine, cervical spine surgery. He's associated currently with NUH Spine Center. May I welcome Dr. Reuben Soh to deliver his talk on effect of perioperative cervical alignment on surgical decision making.
Hi everybody. Thank you, Niraj, for the introduction, and thank you for APSS for this opportunity to talk about this topic that we face every day, which is how do we want to calculate and make sense of cervical alignment when we do surgical decision making. And so without further ado, let's start. So I guess, when we look at the spine, everybody's cervical spine, we look at the alignment, and it's very critical role in spinal biomechanics. Now, in an abnormal alignment, where it's very kyphotic or very flat, it can actually lead to accelerated degenerative disc disease. Interestingly enough, many of the patients now whom I'm seeing for many years after their adolescent idiopathic scoliosis, sometimes we didn't give them enough thoracic kyphosis. And so as a result of that, they start having pain in the lower cervical junction because they are actually in slight kyphosis as a result of the insufficient kyphosis at the thoracic spine. And so surgical planning really is important when we're trying to consider the outcomes for sagittal alignment and for planning our patients for surgery, and particularly when we plan for the sagittal alignment. Now, when we classify the sagittal alignment, we of course have four main types of alignments that you see. Now, this patient, the Toyama looked at this many years ago already in 2003 in Journal of Neurosurgery, and there are really these are the four main types, right? Lordotic, flat, sigmoid, and kyphotic. And the C2 to C7 alignment is the main determinant of what is the classification of one versus the other. And I think this is a very straightforward way of just looking at it when it comes to any patient that we are planning for surgery. However, it's important to recognize what is normal. And I think there's large variation between population to population, race to race. But what I found, of course, is that in many of our Asian patients, they don't really have that much cervical lordosis. In fact, most of them are fairly straight. And this is also further illustrated by this paper that came out of from China by Tang. And it shows that actually females generally have less cervical lordosis than their male counterparts. right? And these are normal individuals, just normal people on the street. But but the average is roughly about 10 degrees. So if you think about it, 10 degrees is not really that much. It's actually very little. And therefore, the targets that we are needing to shoot for actually are not crazy numbers. And therefore, in our population, you don't really find people talking about hyperlordotic cages or trying to restore hyperlordosis or lordosis, because many of the times, by simply doing the operation that we've been doing for years, we are already reaching what is normal, which is about 10 degrees. And of course, every level is affected differently, right? And the more the distribution of cervical lordosis, you can see here, the most of it from this circle here is at C0 to C2. And most of us, of course, are operating between C4 to C6, right? And C4 to C6, actually, they are kind of equal. When you look here in the light blue, the red, and the yellow color pie, they actually don't really consist of that much of the cervical lordosis. And therefore, I think many a times when we are doing segmental fixation, two segments, one segment, nothing really is happening. Everything else is compensating around what we are doing. And so as a result, gives us a reassurance of the science behind why when we do certain surgeries, our patients get away fine, even though we may not have totally gotten the correct lordosis that this patient requires. And so I think this is probably something that to reflect on when it comes to our own practice. However, it's also very important to reflect that in patients who have rheumatoid arthritis or have some abnormality with the C0 to C1, that is where this can have problems in terms of their total alignment, because C0, C1 has actually C0 to C2 rather, the most amount of lordosis actually comes from that segment. So when it comes to surgical strategy, I think, of course, the workhorse for cervical spine is ACDF. I think it has definitely been shown that it is best corrected in straight and kyphotic profiles. And sometimes, and lordotic cages do help with restoring alignment. However, to do that, of course, one needs to also have proper positioning pre-surgery to make sure that this is really getting that lordosis that you require. In terms of laminoplasty, I think laminoplasty preserves the lordosis better in high curvature patients, but in terms of pre-op alignment, I think that is probably the most important choice between anterior versus posterior approach. So you can see here, well, when it comes to fusion, the fusion actually is not as good in terms of the preservation, but for laminoplasty, I think it's a bit better. And I think this may be particularly related to the amount of dissection around the soft tissue. So, of course, the most important when it comes to cervical spine is adequate decompression. And so you see this patient here, where he has a large kyphosis, and you can see also that there is OPLL with even the double C sign that's showing that there's dural ossification. So these patients, they don't do so great when it comes to doing posterior decompression and in terms of achieving good lordosis to allow the float of the cord, and therefore we use the K plus and K minus as part of the understanding of when is the appropriate time to do from the front, when do we need to go from the front first, and then go to the back, because we want to achieve that kind of lordosis to give a subsequent decompression. So you can see this orange line highlights that the kyphosis is cutting through the region where there is where the cord is supposed to float to. So this then, of course, will require us to realign the spine. So this is the same patient where they undergone a float osteotomy, and so you can see that the dural ossification segment has floated into the corpectomy region, and therefore allowing it to be able to give adequate lordosis, which will then allow adequate decompression. So this is like a final CT and final follow-up for this patient about 1 year down the road, which shows adequate decompression. So I think generally they have quite a number of patients with OPLL. I think in our population, there is many of them who have continuous, but when it comes to segmental patients, I generally try my very best to select a patient to do a float osteotomy because that really allows the lordosis to be restored appropriately. And I think going from the front is still slightly more comfortable, minimally invasive, and of course, while we understand there's a risk of dural tears, we usually just go around the mass of the OPLL to do a float osteotomy and allow it to float into the corpectomy space. From the evaluation of our patients in our outpatient, I think always obtain a pre-op CT. I think that is because of the commonality of OPLL in our practice. And of course, with those with long segments, I definitely can generally still choose a canal expansion laminoplasty. So on a day-to-day basis, I think I analyze the pre-op erect cervical spine. If there is a normal posture, I will select to do a standing scoliosis X-ray and just measure the cervical parameters, try to look at the C2 to C7, and also look at the T1 slope. Because the T1 slope is going to be very big. This patient probably has an original C2 to C7 larger lordosis. I make a decision on the likely pattern of cervical lordosis and see if I can perform ACDF because I think ACDF is still my workhorse. But of course, if I cannot, then I will need to then go to the both front and back, which is required sometimes when we do a large corpectomy. Yeah, and of course, if it's multi-segmental, I do then talk about laminoplasty. And in generally, patients who have poor range of motion, they will then need to do a fusion procedure from the back. So my take-home point really is that most of the time is males and versus females, not much cervical lordosis in females, but more like be aware of the high thoracic kyphosis patient because they then probably have a higher cervical lordosis. Pre-op kyphosis may affect the extent of decompression if you choose posterior, so pay attention to the K-line, and of course, in cases without decide to do a pre-op CT scan, I still prefer the CCDF in the most reproducing CL, and of course, laminoplasty tends to preserve lordosis slightly better in high lordotic patients, while PCF disrupts the tension band and therefore the progressive loss of CL but useful in instability. I would like to, of course, share about the upcoming SMIS and ASEAN MIS meeting in Singapore, and I hope that you can also join us in July 16 to 18 this year. All right, thank you.
Thank you, Dr. Reuben. That was an excellent overview on perioperative sagittal alignment. If I have to ask you one single most important sagittal parameter you would use to decide, apart from lordosis, of course, looking on X-ray, what would be that one single most important parameter you would look that will change your decision for anterior versus posterior?
I would probably look at the K line to see whether there is any intersection of the line across any of the segments that I'm hoping to achieve. And of course, if the K line is positive, we can definitely still do a posterior procedure. I would also look, I didn't really have time to talk about this, but the T1 tilt, I think is quite important. The T1 tilt is a little bit like the pelvic incidence for the spine. So if the T1 tilt is going to be very big, you probably need to think that this patient has an original high cervical lordosis. And so this may mean that you need to spend a bit more time to get the numbers right during the surgery. So these two factors.
And does overall global alignment come in your assessment when you are dealing? Specifically, K line is mainly useful when it comes to OPLL, but if we talk broadly about degenerative spinal canal stenosis or a degenerative myelopathy, T1, yes, I agree, T1 might help you, but overall global alignment, does it impact your decision or not much?
No, not really. Not really in my population, because I think that I mean these patients who are coming with a very bad kyphosis or or they come into a clinic, they are already bent over, they have a regional problem somewhere else. So I won't really be thinking about the cervical spine so much. So I think for a regular cervical spine patient, I'm just thinking of these factors. Yeah.
Super. Thank you. Thank you, Dr. Reuben. Dr. Ajoy, you had a question?
No, the same question. I mean, you spoke mainly on cervical parameters. I mean, basically, I agree with you that when we are operating on a patient with cervical disease or a cervical myelopathy, we tend to look at local factors. I just wanted to know, I mean, we already covered that as to what is when do you think that you need C2, C7, sagittal vertical axis, or you look at T1 slope? You already mentioned that, and that's what I wanted to know.
Oh, okay.
Yeah.
Yeah.
Okay. Thank you, Dr. Reuben. So we have our next speaker, Professor Yoshiharu Kawaguchi, who is also honorary secretary at APSS. Dr. Kawaguchi has done extensive work as far as anterior versus posterior cervical degenerative and myelopathy surgical treatment is required. Is considered one of the authority in spine surgery in Japan and world across. May I invite him to deliver his talk on which is beneficial in cervical myelopathy, laminoplasty versus laminectomy and fusion. So that's an extension to talk what Dr. Rubens has already delivered. When myelopathy is beneficial with laminoplasty and when we need to do laminectomy versus fusion. Over to you, Professor Yoshiharu. Sir, you are muted. You are muted, sir.
Thank you very much. It's a great honor for me to present this paper. So can I share my slide? Can you see my slides?
Yes, I think it will. Yes, now we are able to see that. Please proceed.
Okay, thank you very much. Today, I would like to talk about our surgical strategy for cervical myopathy, focusing on post procedures. The title of this study is which is beneficial, laminoplasty versus laminectomy fusion. This is my CV. I'm Yoshiharu Kawaguchi, Professor and Chairman of the Department of Orthopedic Surgery at Toyama University, Toyama, Japan. I have nothing to disclose for my presentation. First of all, let me briefly introduce my hometown, Toyama. Toyama literally means richer mountains, and we are surrounded by beautiful mountains range over 3,000 meters high. It is only 2 hours from Tokyo to Toyama by rapid train, so please come and visit us. So let me start with a case. This is an 85-year-old woman with C5 myopathy. She had multi-level cervical cord compression. What kind of surgical procedure would you choose? Generally, we consider either anterior or posterior approach. Numerous surgical techniques have been reported for both procedures. This slide shows our strategy for cervical myopathy. For patients with cord compression at more than 3 levels, we usually select posterior decompression, 1 or 2 levels with kyphosis or K-line minus status. Anterior decompression is preferred. In cases with severe cord compression, we sometimes perform stage surgery or posterior decompression with fusion. Therefore, in this case, we choose posterior decompression. However, the choice between laminoplasty and laminectomy with fusion remains controversial. To discuss which is better, laminoplasty or laminectomy with fusion, we should separate the pathology into 2 categories, cervical OPLL and cervical spondylotic myopathy, CSM. First of all, regarding cervical OPLL, cervical laminoplasty was developed in Japan and has become a standard procedure. The indication include multi-level cord compression, continuous type or mixed type of OPLL, and developmental stenosis. There are 2 types of laminoplasty, double door type, and open door techniques. Our method is the open door, one hinge type. This slide shows the intraoperative view. The spinous process is used on the left side, and artificial bone is used on the right side to maintain laminar expansion. Post-operative X-ray shows adequate widening of the spinal canal. The long-term surgical outcomes are favorable. We have published studies with follow-up longer than 10 and even 20 years. The advantage of laminoplasty include recovery for neurological deficit, maintain in the long-term follow-up, and maintain expansion of the spinal canal. However, unfavorable results include axial neck pain, kyphosis progression, approximately 6% reduction of range of motion of the neck, and about 5% instance of 5C palsy, C5 palsy. Furthermore, it is well known that laminoplasty is not effective in cases with K-line minus. This is one such case, a 60-year-old man with cervical myelopathy due to OPRL and low kyphotic alignment. He had 2 levels of compression at C34 and 56, with a small OPRL at C56. And this was a K-line minus case. Therefore, we perform the posterior laminectomy with fusion using pedicle screw fixation. The screws were inserted safely without complications. Postoperatively, the spinal alignment improved to the straight position. A spinal cord decompression was achieved through alignment collection. Thus, for alignment collection, laminectomy with fusion may be superior to laminoplasty. But what about OPL progression? Several studies have reported that OPL progression is reduced after fusion compared to laminoplasty. Therefore, fusion may also be advantageous in preventing post-operative OPRL progression. However, the Japanese guideline for ossification of the spinal ligament states that clear evidence is still insufficient to strongly recommend additional fusion, although it may be beneficial for K-line minus patients or those with a high canal occupying rate. A meta-analysis showed that laminoplasty and laminectomy fusion had similar neurological improvement, but laminoplasty resulted in fewer complications and better functional outcomes. Another recent systematic review reported that posterior decompression with fusion achieved lower OPL progression and better cervical alignment with similar neurological recovery. The spondylotic cervical spondylotic myelopathy, CSM. One Japanese spine surgeon suggested that when local kyphosis exceeds 13 degrees, laminoplasty alone may be insufficient, and either anti-decompression or posterior collection with fusion should be considered. A retrospective study concluded that both procedures were effective. Laminectomy with fusion required longer operative time and more blood loss, but provide better neck pain relief, whereas laminoplasty preserved cervical mobility. Similar results have been reported in the other comparative study. Overall, laminoplasty showed less blood loss, shorter operative time, fewer complications, and shorter hospitalization. This table summarizes the advantage and disadvantage of both procedures. Laminoplasty, advantage, preserving of mobility, short surgical time and blood loss, short post-operative hospital stay, low incidence of complications. Disadvantage, poor outcome in cases with severe cervical kyphosis or instability, possible risk of laminar declosure and hinge fracture, risk of ocular progression. As for laminectomy and fusion, advantage can be used in cases with instability, possible kyphosis correction, suppression of ocular progression. Disadvantage, loss of mobility occurs, high surgical invasiveness and cost, common complications such as cerebral palsy. So, recommendation, study, surgery, laminoplasty, cases with good alignment, no kyphosis. Cases where post-operative neck motion is important, where less invasive surgery is necessary. Laminectomy plus fusion, cases with cervical kyphosis, more than 30 degrees, with severe neck pain due to instability, severe OPLL, occupant ratio, 6%, K9 minus, we are having a risk of overall progression. So take-home message. Spine surgeon must be able to select the most appropriate surgery for each patient and perform the surgical procedure without any problems. Thank you very much for your attention.
Thank you, Professor Yoshiharu Kawaguchi. It was an excellent presentation. As usual, let me ask you a question. You mentioned that whenever there is up to 1 or 2 level, you want to prefer to go to anterior, and when it is 3 level or more, you prefer to go posterior. If there is a scenario where there is K minus and compression is more than 3 level, when would you choose to go anterior first or posterior first, or still you would only do laminectomy and posterior fixation and fusion? So K minus more than 3 level, when is the role of anterior surgery in your books?
Thank you very much. It's a very, very good question. I do posterior surgery at first, and then we think of anterior surgery as a second surgery. So we
So it's a
think
stage
of
surgery.
stage surgery.
Okay. Okay.
Uh,
Professor Jose. Professor
can I
Jose
ask?
has a question.
Yeah,
Sir.
Yoshi, thank you for your talk. I wish to ask, when do you decide to go to the upper thoracic spine in your posterior fusions? Do you have any guidelines for that?
The cases is clear code compression at the upper thoracic, such as OPL progression to the upper thoracic. That is the case. And also if we must correct the alignment of the cervical spine, we sometimes do the upper thoracic surgery in addition.
Okay. Can I ask 2 questions to you?
Yes,
Yoshi?
Doctor. Yes,
Yeah.
yes, Dr. Ajoy.
Yeah. Number 1, what if you are doing an OPLL, a posterior surgery in somebody who is young, a 40-year-old? Would you prefer to instrument so that there is a less likelihood of progression as compared to somebody who is 70 years of age?
Thank you very much. It's a very good question. I think the neck must be mobilized. So the fusion itself is fixed and no mobilization after surgery. So I will ask the patients, I will preserve your motion, neck motion, but you have a risk of open progression. Maybe you will have additional surgery in future. So the patient accepted my answer, so I will do the laminoplasty in this patient, in the young patient. Yeah.
One more question. Now there is a lot of discussion. If you look at US, they do not stop at C7. Whenever they instrument, they tend to go to T2. Therefore, what is your opinion on that? You think it's necessary to go to T2 most of this time, or can you stop at C7 whenever it's indicated?
Fortunately, I have no cases with adjacent segment disease at below C2. So I will stop at C7 mainly.
Okay. Thank you.
Thank you.
Thank you. So may I include Dr. Reuben also here to answer one of the question along with Professor Yoshiharu. You said that L1 tilt, where L1 works like a pelvis, whenever you are dealing. So sorry, T1 tilt. So whether T1 tilt has any impact when you cross your T1 and go to T2, the way Dr. Ajoy mentioned. Questions to both of you, Professor Yoshiharu and Dr. Reuben. Maybe Dr. Reuben, you want to take the question first?
Okay, so I generally find that I don't go often into the upper thoracic region, even though sometimes I feel that the alignment of this patient is very kyphotic, because I think we are quite fortunate where many of our patients, we can, by doing doing facetectomies during the posterior cervical procedure, you're able to bring the patient's lordosis back sufficiently. In patients where I think that the lordosis is really quite affected, then I may go down to do the pedicle screw into C7 to help it as a good anchor point. But hardly we've gone past into the cervical thoracic junction. And of course, alignment, apart from doing the alignment and adjusting with the implants, we also have an assistant who can scrub out, adjust the head during the procedure to get the desired lordosis before locking up the screws with the rods. So I think these are some of the adjuncts, and thankfully I've had not to go into the upper thoracic spine. But we do reserve that for revisions, and if we do have cases that with the revisions that break down at the cervical thoracic junction, definitely we will revise into the upper thoracic spine, but not routinely.
Okay.
Generally, I agree with Reuben's the opinion of the Reuben's. But one thing, when I think of the postural decompression fusion below C2, there's a case with the head drop syndrome.
Okay.
We have a lot of patients with head drop syndrome in Japan right now.
Okay. Professor Ajoy, let me ask you one question. You have seen every region has a specific requirement as far as cervical spine goes up. Japan has a very high number of OPLL. Our part of the world, we see more often than not, degenerative spine. So what's your take on your own questions, when you would want to go for upper thoracic? Considering our Indian diaspora. You are muted, sir. You are muted, sir.
The number one question I would like to answer, our incidence of OPLL is not less. We did a study and our incidence of OPLL is equivalent to that of Japanese population. In South, we see a lot of OPLLs. Number two, in a degenerative spine with myelopathy, I tend to go to T1 or T2 only if there is a cervicothoracic continuous OPLL. When I need to do a laminectomy of C7 or part of T1, then we tend to cross the junction. Unless you are doing a cervical deformity correction, like a dropped head syndrome, we usually do not cross the cervicothoracic junction. Any dropped head syndrome due to any cause, ankylosing spondylitis, dropped head syndrome, or some revision surgeries. Otherwise, unless there is a deformity correction, For a myelopathy, we tend to cross only if there is a OPLL in the cervicothoracic area.
Okay. Professor Jose, you had a question?
Yeah, actually, the reason why I asked earlier is that I agree with Ajoy that, for instance, if I need to do a decompression which will include C7, I would go down to T1 or even T2 because we've had some screw breakage from those. And when do I do this? Usually we don't really have much OPLLs involving C7, but if I need to do a foraminotomy of the C7 region, then I'll go ahead and fuse lower down to the upper thoracic, even though my laminectomy might end at C6 because we've had cases of junctional problems there. Thank you.
Okay, thank you. So if no more questions, we can go to the next speaker, who is Professor Jose Ignacio from Philippines. He's an orthopedic surgeon, another leader in cervical spine surgery. So he's going to talk on navigating the choices for anterior cervical procedures in clinical practice. Over to Professor Jose.
Okay. Can I have the slides, please?
Yes, it's loading, I guess. Yeah, we can see your slide.
Good day. I am Jose Manuel Ignacio from the Philippine Spine Society, and I wish to thank, first of all, the organizers for this invitation to be with you here today. And I wish to share how I navigate around choices for anterior cervical procedures in my practice. I have nothing to disclose. I have a patient in front of me in need of anterior surgery. Do I fuse? Do I do ACDF with plate and cage? Do I use a standalone cage? Do I do motion preservation with arthroplasty? Well, I read that fusion will lead to earlier adjacent segment degeneration, that fusion surgery takes longer, that single-level fusion will actually perform just as well as arthroplasty, that arthroplasty provides superior overall results, that arthroplasty is more expensive, and so on. Let's try comparing. This is a systematic review and meta-analysis of RCTs comparing long-term results of arthroplasty versus ACDF. And our findings was that arthroplasty had higher long-term success rates, better functional outcomes, and less symptomatic ASDs. However, in their study, they still stated that they need more multi-center RCTs with longer-term follow-up. Now, what are the perceived disadvantages of fusion? Of course, loss of motion, inferior improvement in pain and disability, ASD. Let's look at them one by one. RCT comparing arthroplasty with ACDF, systematic review and meta-analysis showed that CDA and fusion were comparable with potentially greater success rate in overall neurologic outcomes in arthroplasty. Arthroplasty had lower incidence of ASD. Arthroplasty had lower incidence of reoperation rates and longer operative time. Now, let's look at arthroplasty versus fusion in return to work. This study showed that the percentage of patients who had arthroplasty were significantly higher compared to fusion surgeries at return to work at 6 weeks, 3 months, 6 months, and significantly earlier return to work by an average of about 10 days. Now, 10 days, whether it's clinically significant or not, remains to be discussed, but that was their conclusion. And there was no difference between the two after 2 years. Now, we hear that a lot of arthroplasty studies were industry sponsored. So do they actually affect the outcomes? This is a study, a recent one, comparing single-level arthroplasty and fusion and whether the results would be equivalent in patients who actually were included in industry-sponsored studies or not. And they found that in the high-quality RCTs, findings were similar whether they were industry-sponsored or not. And their findings is that both appear equivalent in results, and arthroplasty potentially decreases the risk of future surgeries. Now, let's look at ASD. This is one of the most cited advantages in performing arthroplasty. This is looking at ASD in single-level fusions compared to arthroplasty. And looking at 6 prospective randomized studies, what they found was that the reoperation rates are actually no different. So these are what the studies in 1,000 over patients show. And in these studies, there appears to have been a bias favoring arthroplasty because a patient follow-up was actually more reliable. Now, looking at a review article, whether ASD after fusion is actually true. Well, this is just an opinion, but it is stated that CDA was recommended for younger patients without significant spondylosis, and I'm sure this is true across the board. So there appears to be selection bias. The basket cases go to the fusion. So they concluded that ASD may actually be part of the natural history and partly due to the fusion. Now, looking at kinematics of fused and unfused or arthroplasty next, they looked at kinematic measurements of the cervical spine as a whole after these 2 procedures. And what they found was that there was no difference in adjacent segment range of motion and centers of rotation between the two. What does this mean? In fusion surgeries, the adjacent disc may actually not be that stressed. Thus, the hypothesis that fusion will lead to radiographic ASD compared to arthroplasty is not supported in this study, and these were 7 RCTs. Now, looking at, again, adjacent segment pathologies in a long-term outcome in a randomized trial. They looked at patient satisfaction and protection versus ASD after 10 years, and there were 153 patients randomly assigned, fairly good follow-up. And what they found was that adjacent segment pathology between the 2 procedures were no different after 10 years. And actually, the cervical SVA from baseline and after 10 years appears also not to be any different. Conclusion was that both clinical and radiographic assessment for adjacent segment pathology were not that significantly different. Reoperation rates, if done for adjacent segment pathology, was similar between both groups, and the preservation of motion in disc replacement appears not to have prevented adjacent segment pathology. Now, let's look at another implant for fusion, the anchored spacers or the standalone cages, and comparing this standalone cage with ACDF for multi-level CSM. They found that both will actually improve and maintain lordosis. The anchored spacers were actually simpler, had less operative time, less blood loss, and less risk for dysphagia. And clinical success rates were the same. So, beyond 1 month, the incidence of chronic dysphagia was also lower in the standalone cages. The incisions were smaller, and although short follow-up time was seen because this is a fairly new device, adjacent segment disease is not frequently reported. Now, comparing between ACDF and cage plate, the standalone cages, the results was that with regards to blood loss, dysphagia rates, and ASD, standalone spacers significantly outperform ACDF. So it is at least non-inferior. Now let's look at clinical outcomes. Now, looking at, again, a long-term study, this was a study cited earlier comparing fusion with disc preservation, motion preservation. The CDA was statistically better. But if you look at the minimum clinical improvement difference, this was not reached. Looking at this time ACDF and standalone cage, comparing clinical and radiographic outcomes, the results show that both groups actually increased C2 to C7 counts. C2 to C7 range of motion was likewise preserved in both groups. CDA, though, had higher rates of heterotopic ossification. What about standalone ACDF? Okay, comparing this time both standalone, disc replacement, and ACDF, how do they fare? So this was to look at the difference in post-op sagittal alignment in the treatment of radiculomyelopathy to determine if the post-op sagittal alignment impacts clinical outcomes. Now, what they found was that clinical scores were no different. The C2, the global lordosis or global cervical sagittal profile was no different between all of them. And arthroplasty, which is considered a lordosis producing surgery, did not show to be different within the other groups with regards to sagittal profile. So comparing standalone cages versus CDA, again, there was no difference in clinical outcomes. So in conclusion, arthroplasty is shown in many studies, but not all, to be better with regards to reoperation rates and understandably greater motion preservation. Patients undergoing arthroplasty have a more stringent selection criteria, providing a selection bias, whereas the ACDF cases, you might want to say some of the basket cases get thrown to them. So studies on standalone cages may actually show equally good results with regards to ASD. So in a level playing field without bias and strictly adhering to the principles of avoiding dissection close to adjacent discs and comparing only cases which are of equivalent amount of degeneration, arthroplasty is seen to have definite advantages but may not always be superior to fusion. Thank you very much.
Thank you, Professor Jose. It was an excellent summary of all the anterior procedures. Any questions from the panel?
Yeah, I will ask
Ajoy?
first, Niraj. See, the question
Yes,
for me
please.
is that I agree that in a single level discectomy for a soft disc or even for a soft myelopathic disc, probably the results are better with CDR. But what I find difficult is that in my practice, when I am doing for a myelopathy, there is always a need to excise the posterior part of the vertebral body, the so-called fish mouth or an inverted funnel type of decompression. And then it becomes more difficult to place a cervical disc. What's your opinion on that?
Yeah, that's true. That's recently I've been a fan of standalone cages, faster surgery, and those standalone cages can actually work for the cases you just mentioned. For 2 levels, they're okay. For 3 levels, probably they will work as well, but I start to worry because most of this is a fairly new implant. It's not really that new. And many of the studies are 1, 2 level, but I believe even in 3 level, we just have to watch out for fusion in these cases. But I don't think arthroplasty will work as well in those cases you mentioned.
Okay.
Maybe.
Professor Jose, yeah. Professor Jose, I have a question. You more or less compared equally your ACDF and standalone. Single level, again, doesn't matter much, but when it goes to more than 3 level, and you said it's quite recent introduction. So if you are doing anterior procedure with 3 or more level, for example, would you go for standalone or you would want to plate it? We are not keeping TDR as an option here because I guess, we have Dr. Dennis Hay who's going to talk more on that. But what would be your choice? You would go for a conventional plating or you will use standalone even if it is more than 3 level?
The standalone, I think, will still work if you are in the mid cervical. Technically, in the uppermost cervical, because you have to put your screws in that manner, the chin may cause interference and you may have technical difficulties. In the lower cervical, the same may be true, but it's more worrisome in the upper cervical. So in the mid cervical, 3 level, I think in clean cases, I would go for those as well.
Okay. All right. So if no more questions, maybe we can go to the next speaker. We have our next speaker, Dr. Dennis Hay, another stalwart from Singapore who has extensive experience in motion preservation surgeries in cervical spine. So Dr. Jose has actually stirred the hornet nest by comparing disc replacement versus fusion. Now, Dr. Dennis is going to speak more in depth on where the motions preservation in cervical spine stands in 2026. What is the role of ACDF versus TDR and hybrid? So he's going to talk on more extensively on motion preservation in today's time. Over to you, Dr. Dennis.
Okay, can everyone hear me?
Yes.
Okay, let me try to share my screen. Okay, everyone can see my screen?
Yeah, it's loading still. Give us a second.
Can you see it now?
No, we can't see your screen yet.
Is it visible now?
Not really. Yeah, now it is visible.
Okay, thank you for inviting me. I do have quite a number of slides to show, but I do know that I have 13 minutes, so I start my stop clock now. So there are some certain slides I will race through. So those are just pictures. Please pay close attention to what I say rather than what is shown on the picture sometimes, because you may miss the details. So as a disclaimer, I think I made this presentation more of in the frontiers rather than the current state of art kind of a lecture. It is not meant to be comparing between anterior and posterior. Of course, a lot of pathologies you may choose posterior, but here we're talking only about anterior and particularly ACDF, ADR, or hybrid. I think with improved understanding of disease pathology, the tools that we use, the instruments, with evolved techniques, with groundbreaking technologies and capabilities, AI, navigation, robotics coming in, and heightened patient expectations, the world will go more and more towards motion preservation and minimally invasive surgery. And there are many examples of these surgeries. What's in the literature, I think Dr. Jose has already given a very detailed talk about it, so I won't go too much into it, but primarily ADR in prime indications better or equivalent to ACDF. ADR in multiple level indication and expanded indications lack evidence, inconclusive. Expanded indications should only be done in regular or skilled ADR practitioners. ACDF today remains the gold standard, but with multiple levels, issues of stiffness, pseudoarthrosis, adjacent segment disease becomes a concern, hence alternative may be required. And hybrid appears to be a feasible alternative where multiple level surgery is required. And why are ADR surgeons or hardcore ADR surgeons fanatics? There must be a reason. They're either crazy or they know something that, or they've seen something that others don't. Fusion surgery have clear issues. We talked about that just now. We have long track record, the history of fusion surgery, talk about stiffness, pseudoarthrosis, adjacent segment disease. And finally, if you do not want to be either a fanatic or you do not want to stay with the conventional fusion surgery with the possible complications, then perhaps a hybrid, being a hybrid practitioner is a good alternative. So personally, I think this is my own personal statement. There is no doubt to me that ADR gives a superior outcome compared to ACDF. And why do I say so? There are 3 things that must satisfy. One is one must realize that ACDF is a completely different operation compared to ADR. So in every step and every way, okay? So ADR must be different in every step, not just the implant. And ADR, it must come with a willingness to change, to accept motion preservation ideology and techniques, relinquish fusion techniques and ideas and techniques before one can adopt it fully to get the results of ADR. And it does come with some learning curve and a poor match of skill sets to indication, meaning that you're stretching the indications when you're not used to ADR motion preservation surgery, you get more complications. But should anyone be willing to learn and persevere, I'm sure that they will not regret ADR being the best. And of course, the champion always gets more injury, like a torn ATFL, meniscus injury, rib fracture, rotator cuff tears. So these are the things that you burn as you practice. We know the advantages of ADR. Okay, naturality protects adjacent segments. This has been shown in the literature to some extent. But I think one thing I want to stress in this talk is ADR protects the level of surgery, not just the adjacent level. It protects the level of surgery from implant complications. And if this is so, then it will be ideal if the indications are expanded. If I would do an ADR and expanded indication level, and I were to give the best outcome because the implant will not have a problem, then that is ideal. Why do I say it protects the level of the surgery? Because just imagine that our spine moves all the time. The implant should accommodate the movement. Should the implant not accommodate the movement, you have additional stress at the implant bone interface that results in a catastrophic failure, either as a form of subsidence or migration. And in ADR surgery, cervical spine, the rate of subsidence, prosthesis, catastrophic failure is close to zero, okay, if you understand motion and the need to generate motion. And that's the reason why prime indications ADR never had major issues, because the spine is moving. If you do an expanded indication ADR and you do not generate motion, you are in deep trouble. Okay, so provide a good release and remobilization is key. And I won't go into detail. These are all the step differences between ACDF and ADR if you want to adopt ADR. And when you stretch to indications, there are different levels of indications. We published this in the AO manual book, where level 2, level 3, level 4 are more difficult levels, and of course comes with higher complication rates. So again, like I said, move from 1 to 2, and most of us should be able to stop at 2. If you want to push the boundaries, that will be 3 and 4. And the whole idea is about generating motion and reducing motion, what I call motion control, because you can do additional release to make a stiff segment mobile, and you can use implant designs wisely to control the mobility and hence delivering it in expanded indications. But do bear in mind, success rate is usually high in prime indications. When you start to stretch, more and more complication, and hence the technique is extremely important, or else you end up with a catastrophic failure. If you respect the techniques, well, the worst outcome of ADR is a fusion. What are so-called contraindications out there, right? So more than 80% of cases have these problems. As a result, true indication for ADR is very little, right? So age-wise, it is usually indicated in 1-2 levels only, following guidelines. If you have stiff joints, either of these, loss of disc heights to a certain number of millimeters, extensive syndesmophytes, reduced mobility, or you have hypermobile joints, if you have deformity, if you have osteoporotic bone, you have facet joint arthropathy, you don't qualify. That's what's stated in the literature. So I must just share a little bit of slides. If this patient has a good outcome for me, this patient has a good outcome for me, if this patient has a good outcome for me, and this has a satisfactory outcome, I don't see why expanded indication ADR will not be the future. What are the real contraindications? Why do I talk about real contraindications? Because real contraindications therefore mean that these patients or these levels will require a fusion rather than the ADR, even in stretched indications and very expanded techniques. These are the 4 main things. 1, substantial posterior compressive disease like OYL. Okay, we do understand that with a certain degree of height increase anteriorly, you can actually distract a 3-column spine to allow distraction of the facets behind and hence the ligamentum flavum. But in OYL cases, especially when dense OYL is present, this is contraindicated. A massive unresectable retrovertebral disease like continuous OPL is not resectable, all right? It's not resectable. Chronic structural scoliosis with unpredictable facet stiffness, again, is not ideal. Okay, you can still do an ADR, the motion is going to be affected, and you may not get the desirable outcome of an ADR. And of course, vertebral bone, vertebral body anomalies may not be correctable even with lordotic ADR implants that are available in the market. So ADR, it's important to recognize that ADR is a disc procedure. Okay, ultimately it's a disc procedure. and it all is a disc corridor procedure, meaning that whatever you're doing, the decompression must be accessible through the disc corridor, right? And number two, ADR release, which we do to mobilize the spine, is a direct anterior release and an indirect posterior release, giving a 3-column stretch, all right? So what does that mean? Anything that is causing stiffness or deformity anteriorly can still be done with the ADR, anterior procedure. But anything that is stiff posteriorly, especially when it's not balanced on both sides, is going to be difficult to rebalance the spine unless you do a separate posterior approach on top of the ADR. So just some case illustration. Substantial posterior disease case, a patient of these x-rays. I'm going to fly through this with a 2-level disease. Primary surgeon looks at the CT scan, does a 2-level ACDF. Okay, so this is 2 years later, develops myelopathy because of adjacent segment hypermobility. You can see more movement at the C3, C4. Okay, comes back with a stenosis C3, C4. Patient has a relatively flat lower cervical, fused segment, and hence there is a need for hyperlordosis at C3-4. And this has caused extension need for that level, resulting in retrolisthesis as well as buckling of the ligamentum flavor. So in this case, we did the ADR for the patient, moving very well. However, if you look at the post-op, there is still substantial ligamentum flavor because this patient requires extension even when you have a mobility in the normal erect neutral position or extension position. There will still be significant ligamentum flavum buckling, insufficient for ADR, right? So in this case, we had to go in again posteriorly, do a UB to do a posterior endoscopic decompression. The patient did very well after that. Another patient showing OPLL contraindication, right? But only for solid, huge OPLs is contraindication. For small resectable segmental, it is still a possibility to do an ADR. So in this case, we have shown a successful case first of ADR being done in these 2 levels, where there's OPLL segmental, resectable. We use the O-arm navigation and we resected the vertebral body, as you can see, clearly in the center, ensuring that the balancing as well as the weight-bearing mechanics is still feasible. And we did an ADR surgery and it is successful. However, in this case, where again you see a disease, stenosis, and then you have an OPLL, dense OPLL across, and we have resected it. Intraoperatively looks okay, but the weight bearing of the implants of the middle segment has failed on the top part, okay, resulting in a post-op subsidence, and hence you have a hypermobility at that segment. Fortunately, because the spine is moving very well, so the patient has no pain and is still asymptomatic. So this patient considered a success clinically, but radiologically it is a failure. The full body balancing for the patient. ADR generates a total of 4 possibility outcomes. One is it corrects the deformity, okay? It corrects the deformity and allows motion. 2, it does not correct the deformity, allows motion. 3, it corrects deformity but no motion. And 4th, it does not correct deformity and no motion, right? So the outcomes of all 4 are different and it's going to be more distributed compared to ACDF, which only generates 2 outcomes. Corrects the deformity with no motion or does not correct the deformity with no motion. Ultimately, motion is what is more important than the deformity correction, because once you get the motion, I stress that, once you get the motion, you can accommodate many alignment. So alignment is less crucial because of the accommodating effect of the ADR. Let me just try to move on to the next slide. Okay, so this is a case where we clearly demonstrate that posterior release is unreliable. So you can open up in the patient with scoliosis, with his facet joint stiff on one side, but with time, it fuses very fast, simply because the balancing of the posterior facet joints stiffness is poor. This is an indirect balancing of the posterior stiffness. Unless it is anterior stiffness, then that can be balanced easily and corrected. Vertebral anomalies, if the vertebral body is waxed, radiologically, you may not get a good alignment. You can, however, still get the possible of some mobility. Is the pre-op and the post-op CT and MRI scans showing adequate decompression, but I would say less than ideal alignment and mechanics. When do we do a hybrid? In my opinion, not because of the need for a multi-level surgery, we choose a hybrid. Of course, there are recommendations to say that 3 levels, 4 levels, not indicated for ADR surgery, but I don't think that should be the main reason for my practice, okay? However, there are some times where certain levels really are contraindications for ADR, and those are the ones that I would do a fusion surgery. And of course, there will be some times where you need to convert it intraoperatively due to complications we'll show a case later. And of course, I'm going to more and more towards level-specific surgery, where perhaps some hybrid surgery is ultimately a level-specific surgery because you are titrating it such that certain levels require fusion, certain levels require disc replacement. Even for disc replacement surgery, one can go hybrid to make sure that the mechanics of every single level is stored, or in a hybrid front-back kind of a fusion to generate the best outcome for the patient using the best approach and the most minimally invasive surgery. This is just a simple case of a possible conversion. For all ADR surgeries, I want to stress there must be a standby ACDF, particularly if you're doing expanded indication. So, patient with a simple clear-cut disease shown here, and during the surgery, as you can clearly see, vertebral fracture results due to poor release, and the result, one level is converted to a fusion, and hence a hybrid. Like I mentioned before, hybrid is when one level is indicated for a fusion, either intraoperatively there is a problem, or post-operative, or planned beforehand that this is a contraindication for disc replacement surgery. Outcome otherwise is good after that. I want to use this case to illustrate some understanding of hybrid. If you do look at this case, a fusion level actually generates a long lever arm. So hybrids are good because are generally good outcomes because the long lever arm will ensure mobility of the adjacent segments. And similarly, the adjacent segments, as you can see, ADR allows mobility. That dissipates stress. And that dissipates stress, allowing better fusion and faster fusion for the adjacent levels. So there is actually complementary effect of the hybrid when they are placed one over the other, adjacent to each other. I will still say that to be able to preserve mobility for all is the best. So hybrid is second best, probably better than all fusion if in long segments. Fundamentally, I think with the fusion, it still disrupts mechanics and it can be disastrous at the end of the day. So these are just alignments showing post-op. I want to illustrate this particular point on alignment and how it can be a disaster looking at alignment parameters. So this is the last case, patient with the ACDF done 2 levels with the ADR done above. Okay. Patient did well for a year, started to have problems thereafter, increasing in neck pain, radiating pain with radicular pain. So MRI scan is done again to show that there is a stenosis at 3-4. And this is the previous MRI scan prior to the index surgery done somewhere else. Clearly 3-4 already is stenotic, but perhaps the surgeon has chosen not to deal with it, but has made it worse now simply because surgeon has fused it in a straight neck, resulting in need for hyperlordosis higher up. So the ADR implant is placed a little bit anterior, unable to support the movement, and the level above at C3-4, which was already stenotic to start out with, has gone into more hyper extension due to the need for compensatory mechanisms of altered biomechanics. So in this case, we've analyzed the situation, we've done the CT scan. Fusion is good for both levels. The ADR is still moving, but minimally. So the CT scan showing some bone loss due to the previous fusion and ADR. This is the X-rays of the patient with side bendings, and this is what we did. We, of course, dealt with the alignment at C3-4, which was supposed to be dealt with previously. We changed the mechanics of the C4-5 ADR, and we have taken down that fusion to give a better and more harmonious spine. What I call reduction of retrolisthesis, reversal of hyperlordosis, and reconstitution of lordosis, and allowing mobility throughout the spine, constituting spinal harmony. Good C2 to C7 SVA, more harmonious curve, good full alignment, and this is the side bendings, and this is the flexion extension. We are not doing the bottom one because I think that that's unnecessary and difficult because of poor bone quality as well as poor bone shape. Patient has a good outcome. I think the power of CADR can be seen clearly through the earlier slide that I've shown. It can remove pain generator, be it discogenic facetal instability. It can decompress neural structures. It can realign the spine, allow healthy mobility. And I think it's a truly minimally invasive soft tissue preservation approach compared to posterior approach. Seldom emphasize things is why anterior, because it is direct dealing with the pathology most of the time. Why ADR, as I mentioned, it deals with the pathology, preserving the physiology, and in this case, mobility. And truly, the spine is a structure whereby there's front and back pathologies. There's sometimes a need for a 360-degree dealing with the spine with anterior ADRs and posterior endoscopic approaches to give a motion preservation outcome. So this is what we talk about, dealing with deformity, dealing with adult DJ conditions require a combination hybrid of all fusion, TDR, endoscopy. My last slide, I think life is motion, motion is life. Our goal should be set at anatomical, physiological, and biochemical, mechanical restoration, and we are already near. Every patient, every disease level is different and calls for a highly specific therapy. And when choosing the therapy, I think at the end of the day, ADR can be done most of the time for DGen cases up to, in my opinion, 80%, with some ACDS and hybrids. expanded indication ADR from the anterior plus the endoscopic posterior is likely going to be the future and the dawn of regenerative medicine. Thank you very much. And once again, I want to say that we are going to have this combined SMIS AP as well as Singapore Spine Society and ASEAN MIS meeting in Singapore in July. We welcome all of you to participate. Thank you very much.
Thank you, Dr. Dennis. It was an excellent presentation. Let me start by questioning two burning questions, which I have. One, you said that is an extended indication you are doing in a segmental OPLL. And Professor Yoshiharu Kawaguchi said that this OPLL has a tendency to regrow. So what is your experience at long-term in motion preservation in OPLL? And second question is, you revised one of the fusion to the motion. What will be the long-term motion, for this particular segment according to your experience?
Okay, I think the first thing is OPLL. I think if you want to do an OPLL, again, I stress, number one, is it resectable? We have to obey the principles of decompression. And after you resect it, do you preserve enough bone stock stability for the implant? If these two are checked as possible, that can be done with an ADR. However, one more caveat that is when you resect the OPL, this OPL must be almost fully resected or fully resected. It cannot be partially resected. So leaving you actually very little chance for OPL to regrow because you actually resected the OPLL. Hence, I routinely use navigation to ensure the adequacy of resection rather than just using blind feeling using of instruments. The second question is about the takedown. Okay, actually, I think this concept is no different from what we do in lumbar spine. When you have a poorly corrected alignment, a flat back in the lower lumbar spine, what do? You do a PSO, and after you do a PSO, you realign the spine, and then you lock it in fusion. So in this case, similarly, you do an osteotomy, and after you do the osteotomy, you can decide whether to lock it in a new alignment, or if the parameters, like I mentioned earlier on, all preserves, you have good neurodecompression, you have good bone stock, it's going to behave exactly like an ADR, particularly in this patient where multiple segments are ADR with stress dissipation. You're not worried about increased stress at this level causing a failure of the implant. So it should function like a normal ADR. So I think this will do well for the future.
So naysayers about this ADR, they always say that eventually, say 5, 6, 7 years down the line, majority of the fusion goes into a non-fusion. I mean, this becomes an expensive device of fusion, and that is the critique would say. So when you are actually osteotomizing and then re-establishing new motion, wouldn't you a little worried about that disc losing its motion and getting fused?
Okay, so the few points to make. One is a stiffening with time causing eventual fusion is inevitable. Whether it is a surgery or whether it is a normal individual's native spine, the spine ankyloses with time. We have seen natural history of diseases, right? So when we talk about slow ankylosing or fusion, we have to talk about the value, right? When you talk about this is expensive fusion, you are actually putting in a dollar sign to it. So my question back to anybody who asked the same question, which I've been asked so many times, is what is this value? If I equivalent a certain amount, for example, a Singapore dollars of $5,000 to in this patient has a high ankylosing likelihood, 3 years, 5,000 Singapore dollars for 3 years. And then the motion continues until it adapts to the most comfortable position. Is it worth that amount? All right. So my counseling of patients is very clear to the patient. It is very realistic. And of course, in patients where they don't have a tendency to ankylose, and clearly you can see that they can last for 20 years and beyond. I mean, there are long-term studies to show that these have actually possible to go as long as that. So as long as you put in a right number to a right duration and let the patient choose, I have no issues with that because they know what they are buying at the end of the day. Yeah.
So Professor Jose has a question, and then Dr. Ajoy.
Yeah, thank you, Dennis, for your talk. I have a question. If you need to do a revision not because of any neurologic problem, maybe some subsidence or implant dislodgement, will a posterior fusion be sufficient to tackle the problem? or you still need to go anteriorly, revise, remove, fuse, or just a posterior will do?
Yeah. Fortunately, revision of an anterior surgery is not too difficult. In fact, it is pretty straightforward and easy. And even with the ADR takedown, assuming that the previous case is done by yourself with a conscious effort to preserve bone stock, that shouldn't be too difficult to exchange a disc for a disc, in the process doing a decompression again most of the time. There will be some cases, very rare, whereby bone stock is poor, you just can't go anteriorly. Yeah, that you could do posteriorly, and you can use the same methods that has been described. And in the spirit of motion preservation, one can still consider laminoplasty, one can still consider endoscopic decompression. At the end of the day, still preserve mobility for the patient.
Dennis, great talk. My question is that when you're doing a revision and putting a disc in, do you look at the CT scan to see whether the posterior facet is fused? Number one. Number two, I saw a different design of joints, cervical disc you are used. Does the choice of design vary depending on the constraint you want to put into the implant?
Yes. Okay. So I think there are two parts to it, right? Okay, so let me answer the second one first. I'm more and more towards going patient specific, level specific, disease specific. So I do use different implants for different levels. Sometimes anterior, posterior, sometimes anterior, but with different implants, as you can see from the slides. And I look at more than just the anchor, whether it is constrained or not constrained. I also look at the way the articulation allows movement, because this will allow me to know whether this movement I'm going to give to the patient is going to be good or not. In unstable spines where there is clear spondylolisthesis, and even in spondylolisthesis patients, in flexion, do you get a spondylolisthesis, or in extension, you get a spondylolisthesis, is also important, because the ball and socket, or the articulation design controls that movement to be able to ensure that that pathological movement does not occur again. So I use implant designs, therefore, to control the way that the segment moves. Sorry, what was the first question again?
No, when you're doing a revision, you have put a disc in, but do you look at the facet joint behind?
Okay. So the only contraindication for a facet joint disease, absolute contraindication, if it has ankylosed. Even in very, very stiff near ankylosis, that facet joint can be opened up, kept open with a height increase and a 3-column distraction, and does not cause pain. So anterior procedure can actually treat a posterior condition, provided it can be opened up, and that is most of the time the situation. The relative contraindication is what I mentioned in my slides, that is where you cannot predict as the stiffness of both sides, one possibly being more than the other. It is not a absolute contraindication, because you can still do an ADR, you can still open up, but it's just that the spine may flop to one side and stiffen up with a little bit of scoliosis at the end of the day. Something like a expansive fusion that people call it, but in a coronal way, right? In coronal deformity. So I think it is a relative contraindication for that.
Okay.
Okay, so I guess if no more questions, we can move on to our next speaker. Professor Dr. Dongho Lee is Professor of Orthopaedics in Asan Medical Center from South Korea. This professor is going to talk on complications and revision strategies in cervical spine surgeries. Over to you, Professor Dr. Dongho Lee. Dr. Lee, you're muted. Okay, we got you.
Good afternoon, friends. The original title of my talk was this. However, as you know, there are so many complications following cervical spine surgery, so I thought it would be better to focus on one particular situation many spine surgeons could encounter every day. That is pseudoarthrosis, or non-union, following anterior cervical fusion. Before starting the talk, let's first consider a couple of cases. This is a 53-year-old male patient who underwent ACDF at C567 1 year ago. Now, X-rays show non-union, but he has no symptoms. What should we do in this case? If the same patient presents with right arm pain 3 years after ACDF, what should be done? First, we need to consider an important question. Does non-union after anterior cervical fusion surgery truly indicate a poor prognosis? A review of previously published studies shows that this topic remains controversial. Earlier studies reported that pseudoarthrosis is closely associated with arm and neck pain, with 67% of patients experiencing persistent symptoms and 82% requiring additional intervention. However, other studies have reported no clinically significant differences between the solid fusion versus non-union groups. It's very fortunate if pseudoarthrosis is present but asymptomatic. However, in some patients, non-union can lead to actual leg pain, radiculopathy, myelopathy, kyphosis, graft migration, and implant loosening. The important point is that although many studies argue whether there is a statistical difference or not, none of them have shown that the non-union group achieves better outcomes than the union group. Then, how should solid fusion be evaluated after anterior cervical surgery? Fortunately, we already know well-validated and accurate methods for this assessment. CT scan can be used for evaluation. This method was proposed by Dr. Kwang-Sup Song and Dr. Dan Lu. Extragraft bone bridging is a far more reliable and accurate way to determine solid fusion than intragraft bone bridging. Extragraft bone bridging refers to any peripheral bone bridging with cortical density and no lucent lines crossing the peripheral margins of the operated disc space outside the graft. Another method was also introduced by Dr. Dan Lu's group. It involves a much simpler measurement of interspinous motion on flexion extension dynamic lateral views. If interspinous motion exceeds 1 mm, it indicates that solid fusion has not been achieved yet at that segment. Here is another question. If the screws break or migrate as a result of non-union or delayed union, what should be done? Would revision surgery be necessary? To address this issue, we conducted this study. We observed the patients who showed screw migrations less than 5 mm after anterior cervical plating. Screw migration or breakage of more than 2 mm was not uncommon. Although screw failure increased the incidence of pseudoarthrosis, it did not worsen postoperative arm pain, neck pain, or neck disability. Furthermore, failed implants did not migrate to a degree that endangers tracheoesophageal structures, so immediate removal was not necessary. Therefore, it would not be a major concern. Next question is this. If a patient who underwent anterior cervical fusion is diagnosed with pseudoarthrosis on an X-ray 1 year postoperatively, what would you do? Should we simply observe or do revision surgery to achieve fusion? To find the answer, we investigated the long-term results of the patients diagnosed with pseudoarthrosis 1 year after ACDF. We analyzed 89 patients who were followed up for more than 2 years. At post-op 1 year, 60 patients showed solid fusion, while 29 showed non-union. When we re-evaluated the 29 non-union patients and post-op 2 years, union had been finally achieved in 21 patients of them. Overall, the incidence of non-union increased as the number of surgical levels increased. Conversely, the non-union to union conversion rate was higher in cases with fewer surgical levels. Among patients with non-union detected at 1 year, spontaneous fusion by the 2-year mark occurred in 80% of one-level cases, 67% of two-level, and 60% of three-level cases. Patients with Shudo detected at 1 year after surgery may be observed without intervention. That is because approximately 70% will eventually achieve fusion by the 2-year point. The incidence of Shudo increases with the number of fusion levels. Persistent Shudo at 2 years is associated with poor neck pain and higher NDI. Therefore, early revision surgery may be considered if Shudo is accompanied by significant symptoms following multi-level ACDF. Then, what is the prognosis of non-union detected 2 years after surgery? To answer the question, we conducted this study. We investigated 249 patients who were followed up for more than 5 years. Among them, 43 patients showed non-union at the 2-year mark. By the 5-year follow-up, 14 of these patients had achieved solid fusion finally, while 29 remained in non-union. So, non-union to union conversion rate was only 33%. It's quite lower than that of non-union at 1 year. Among patients with non-union detected at 2 years, spontaneous fusion by the 5-year mark occurred in 39% of one-level cases, 35% of two-level, and 23% of three-level cases. The results were the opposite of the fate of non-union patients at the 1-year mark. 67% of Shudo associates detected at 2 years remained unfused until 5 years postoperatively. So, non-union identified 2 years after ACDF may be considered a poor prognostic factor because it has less potential to achieve fusion with further follow-up and a higher chance of worsening clinical symptoms. Therefore, the solid fusion at the 2-year follow-up can be considered an indicator of the success of the surgery. Let's take another look at the cases I presented at the beginning. This is an asymptomatic patient showing signs of non-union 1 year after two-level ACDF. Since approximately 67% of patients would achieve a solid fusion by the 2-year mark, careful observation could be a reasonable approach. What should be done for a patient showing non-union 3 years after surgery with related symptoms? At this point, the likelihood of achieving fusion is only about 35%. So, considering early revision surgery would be a more appropriate option. Let's get this talk summarized. Solid fusion ensures better post-op outcomes, so every effort should be made to achieve this. The most reliable criteria for diagnosing union are interspinous motion of less than 1 mm and extra graft bone bridging on CT scan. Mild screw migration or breakage does not typically require immediate intervention and can be managed with the wait-and-see approach. If non-union is detected at post-op 1 year and the patient is asymptomatic, observation alone is sufficient, as fusion can still be expected in 70% of cases within 2 years. However, non-union detected after 2 years is considered a poor prognostic factor and early revision surgery may be necessary. Thank you very much.
Thank you, Professor Lee, for a lovely talk. So let me start the ball rolling by asking a question. Professor Lee, you said that 1 year, if your patient is asymptomatic, you can probably wait and watch, and 2 year you term them as a non-union. Would you do anything particular if you see, say, 6, 7, 8 months down the line, you get a CT scan done and you see that there is not much bone formation? Would you intervene, or when you will stamp that, okay, now this is not delayed union, but it is actually a non-union or a pseudoarthrosis? What is your time period about that?
Thank you for the good questions. That is very important question. So I think that according to the papers we published, the appropriate time to assess the non-union is 2 year point after the surgery. So if one of my patients shows the insufficient bone formation even after 8 months after surgery, that is kind of the progression of the spontaneous bone formation. If the patient doesn't have any symptoms, I will just wait and see. So if the patient continuously shows the arm pain and insufficient bone formation at 2 year point, which means that the poor prognostic factor, I will consider the early revision surgery.
Thank you, Professor. Have you ever seen that, this patients, even at 2 years, they would be sometimes clinically asymptomatic? So would you still wait, or you would intervene at 2 years?
Oh, yes. In many patients who shows the pseudo motion even after 2 years, but the patients, if the patients doesn't have any symptoms, so I think that we don't need to touch them again. So every case of a non-union means the unsatisfactory result. If the patient has a non-union, but fortunately it doesn't have any symptoms, so it doesn't make any problem.
Thank you, Professor. Yes, Professor Yoshiharu, you had a question?
Yes. Thank you very much. This is a very, very interesting topic. My question is, do you know what is the difference of the pathology of asymptomatic non-union and symptomatic non-union? That is my first question.
So actually, I don't know the exact answer, but as you know, the motion is a very important risk factor for the uncovertebral joint spur, growth of the uncovertebral joint spurs. And sometimes it is a very important risk factor of the continuous progression of OPLM. So I think that the continuous motion after the fusion surgery is not a good sign. So before that surgery, we decide to fuse that segment. That is, we have a lot of reasons to do that. So if we try to get a good fusion mass, then we need to do our best to get a good solid fusion. But I think that sometimes after the fusion surgery, continuous motion would exaggerate the spontaneous bone growth of the OPLR or bone spur. Sometimes the fusion graft or end plate is subsided, and sagittal height of the neural filament will decrease. Sometimes, as Dr. Hayes said, the ligamentum problem could be buckled up of the loss of this kind. So we can think about every kind of possibilities.
Thank you very much. And can I have one more question?
Yep.
Yeah, sure.
Yes, Professor, go ahead.
Yes. In Japan, and as a lumbar spine, some doctors use teriparatide to increase the fusion rate. Do you think is it useful to use teriparatide for the fusion in the cervical spine? And do you have any experience to use teriparatide before and after surgery?
Oh,
in the
yes,
cervical spine?
that is very important question. So the many literature, many papers are saying that teriparatide use is very helpful to increase the fusion rate, particularly in the osteoporotic patients. So I'm applying the teriparatide for the severe osteoporotic patients, but not for every case of fusion surgery.
Thank you. Yeah, teriparatide promotes the fusion rate in the cervical spine. Some papers said so. I try to use the teriparatide in the cervical spine in future. Thank you very much.
Thank you all. So we go to the next session. I guess we have discussed extensively about surgical options in cervical spine. Let's go to the MIS spectrum. Dr. Balamurali is an accomplished spine surgeon from India, and he is extremely experienced into minimal invasive spine surgeries. He's a spine surgeon at Kaveri Hospital. Over to you, Dr. Bala, for your experience into minimal invasive spine surgery with cervical spine.
Thank you very much, Dr. Niraj Vasavada, and thank you, Dr. Ajoy Shetty and APSS for this opportunity. So in the next 12, 13 minutes, I'm going to try and cover the important aspects of MIS in cervical spine, what's its current role and its limitation. So as we all are aware that, we have gone through an era of open surgery, starting from Cloward and Smith, and then more popularized in the posterior cervical, and then into tubular era. Now we are in the endoscopic era, added with robotics, navigation, and so many other technologies that's coming up. So I'm just going to touch base on some of these aspects with some of my own experience, as well as what is there in the literature. So the most common indications where MIS has popularized itself is in the disc, in CV junction, in myelopathy, trauma, tumors, and to some extent in infection. And there is a lot of literature which is more among cervical disc, myelopathy, and trauma. So like in any MIS surgery, the open surgery, which has the disadvantage of wide exposure, muscle injury, is all overcome by MIS techniques with advantage of less muscle injury, visualization, but there's still learning curve, there's still versatility and understanding the anatomy, and it is cervical spine MIS is not something for the beginners. So the clear indications to choosing MIS and why it's becoming popularized is because of muscle preservation, avoiding less iatrogenic, especially in the cervical spine posteriorly, where we can avoid kyphotic deformities in the future. Same with reduced postoperative pain, analgesia, blood loss, hospital stay, cost, faster recovery, and everything else that is the same with any part of the spine. Now, the two major things that we are concerned about and why MIS is very popular is one is pain, especially when we're doing posterior approaches with neck pain, axial neck pain. And the second is the more we discuss about adjacent segment disease, like we discussed in the thoracic and lumbar about proximal and distal junctional kyphosis. So ACDF, which is a gold standard for most anterior approaches, has the disadvantage of an adjacent segment disease. So does MIS address this issue? Probably not, because I consider MIS itself as being a very keyhole, minimally invasive surgery. You can do through a very small 2 centimeter incision. You can add a tube or you can use an endoscope. Cervical arthroplasty, we have seen, again, a single level cervical arthroplasty is a fairly a minimally invasive procedure. And more popularly that we are seeing is being the use of anterior foraminotomy. So this is just approaching right through the anterior approach, mostly endoscopic or through a tube, and it is a unilateral approach where, similar to a posterior cervical foraminotomy, you can approach anteriorly without having to add an instrumentation, a plate or a cage. My experience in this is very limited. I've done only a few cases, but the risk is of a vertebral artery injury because you're going very close to the uncovertebral joint. Spinal instability is very rare in these cases, but sometimes you can get a Horner syndrome from the parasympathetic plexus. So this is a very fairly straightforward, simple approach where you just approach towards one of the unilateral uncovertebral joint, and where you have a fragment which is a soft disc usually, which is a displaced fragment which can be removed very nicely. It's a quick procedure, can be done as a daycare procedure, and no fusion is required. Similarly, ACDF is also being used from straightforward discs up to vertebrectomy, can be done through a tube. This is the exposure is very standard, like you would do for an anterior cervical discectomy. It again avoids any major exposure, and these surgeries are very nicely accomplished through a small tube. Now, coming to posterior cervical foraminotomy, this is what has gained popularity in the last 2 to 3 decades. Initially, posterior cervical foraminotomy was popular in the early 60s, where it was done through open. But now, with the advent of the tube and endoscope, posterior cervical foraminotomy is very easy. So, 1/3 of cervical radiculopathies can be addressed through this. It can be either done through a sitting position, but I tend to use in a lying position or a concord position where you have the head slightly elevated. And your point of interest is your facets, and you dock your tube, and you just have to drill 1/3 of the facet. It is best to avoid drilling more than 1/3 and trying to restrict it to maximum of 2/3. There is literature that up to 2/3 does not cause, especially if there is no segmental kyphosis and the opposite side is preserved. And you just have to do serial dilation. I'm just show you a short video. So you have a small incision, about 2 centimeters, and then you use serial dilators, which are used to get down. And then you identify your facet joints, the muscle is removed, your facet is drilled, the superior facet is drilled, and then your inferior facet. And then you'll be able to see the nerve root, and the nerve root can be decompressed. You can either do this for a soft disc where you can remove the disc itself, or if you have an osteophyte causing severe foraminal stenosis, then the osteophyte can be decompressed. So in both cases, these are a very, very good technique. And the outcome of this is patients can go home the next day, very little neck pain, and the risk of having to convert this to an anterior cervical discectomy is as less than 5%. So this procedure is, however, limited to only doing very short procedures, which are more to unilateral. It cannot be applied bilateral on the same side, not for central discs, not for OPLL, and so the indication is very limited in these conditions. So an ideal case is unilateral, soft disc, or a bony spur where there is no instability. Now, if you look at the literature, from, as I said, from the 60s and 70s itself, you have a lot of literature saying up to 98% or 96% you have pain relief. Many cadaveric studies have shown that, biomechanically, that there is no significant problem with just doing an unilateral facetal removal for removing the disc. And long-term results in several papers have shown that is as effective as an anterior cervical discectomy. And there's no significant difference in the clinical outcomes, complication rates, reoperation rates. And the common thing we worry about is whether this may need to be converted into an anterior cervical discectomy. Again, it's reduced. The risk of adjacent segment disease is significantly less compared to an anterior cervical discectomy. And this is one of the reasons why this is becoming popularized. And the procedure itself is improvised because of the advent of tubes and endoscopes. So there's various comparisons that have been done with both an open as well as endoscopy, and they're both superior. So in summary, these are effective, safe, cheap, and moisture preserving. Now, the application is now moved further forward into various fixation techniques, laminoplasty and tumors, and I'll just go through some of them with my own experience. So most of us have been familiar with a simple anterior cervical discectomy approach for like you do for an ACDF or an odontoid. Well, we have now very simple, elegant instrumentation that are available in order to treat type 2 and type 3 odontoid fractures, either with a single screw or with two screws. So these are very simple procedures where you need to select your patient based on the fracture line and how you're going to be able to reduce it intraoperatively so that you're able to get your screw right through the distal end of your fracture. And this can also be combined with an anterior Atlanto C1 and C2 fixation as well. You can cross from anteriorly into the C1 as well. And so again, all this can be done percutaneously. And with the use of navigation, it is much more better. And whether you use a single screw or a two screw, this is quite superior in doing good fusion. So I use routinely navigation. But with navigation, there's a lot of technical issues that you have to be aware of and how you're able to reduce these fractures. And you're able to get very good reduction. Similarly, you can use C1, C2 transarticular screws. Again, this can be done percutaneously. You can either use a small mini open or you can use percutaneous screws. And with the help of navigation, you can treat at various pathologies of C1, C2 transarticular, either for fracture, for degeneration, or you can even use it for os odontoidium and various other indications. Here's another case of an hangman's fracture, which can be used through a simple percutaneous screws where you pass in through the fracture line. So with the advent of navigation and tubes, this can be done easily. Atlantoaxial osteoarthritis, where we can do a small mini open procedure where you can treat the pain, which is usually patients present with neck pain, which is a very ignored condition, where you again do a small mini open where you're able to see your entry point of your screws, and only if you are able to reduce them, then you can pass and fracture. But usually these are stable for osteoarthritis of C1, C2, and these patients do extremely well. You can either do unilateral or you can do bilateral, and you can have a good range of movements. C1, C2 again is becoming popularized in a similar case of a C1, C2 for an AAD in this patient, where we are able to identify through a small tube, which can be an expandable tube, a Medtronic's tube. And here muscle dissection also is very important for us to be able to approach these. So I'm just going to show you one side, but you need to repeat them on both sides. So once you place the tube, you identify C1, you identify C2 entry points, and then you cross over the joint. And here you can see that you're just dissecting across the joint. You enter into the joint and you can see the vascular structures, the veins. So you don't need to disturb. You don't need to cut C2 as well. I don't do that routinely. And then once you enter into the joint, you can place your screws, prepare the joint, and that's bone graft that's placed into the joint, and then the screws are placed. And again, C1, C2 can be fixed very safely through an MIS technique. This can also be applied to trauma in one of the cases. So the limitations are it's not a direct decompression, and you need to be able to have a reducible AAD in order to do this. And there is enough literature that is available that is showing that these have been used for C1, C2 fixation as well. Cervical myelopathy is another area where a lot of experience is required to be able to do decompression and fusion. Again, it depends on whether there is a central compression, how many levels, what do you need to do, how much fusion should be achieved, because you can go up to nearly 3 to 4 levels with expandable tubes. As you can see in this case, you can approach up to 3 levels easily through an expandable tube. Decompressions have been reported as well. Without instrumentation, just an MIS decompression from unilateral to over the top decompression. But again, as I said, this is not something that you should do if you're not experienced with doing a lot of open techniques. And you need to be able to select your patients. Pedicle screws have been inserted by lateral, bilateral, lateral exposures, where you can use it to correct some simple deformities and decompression. So there is a steep learning curve, orientation of the depth, case selection, early stages, very severe stenosis, severe OPLL. I probably would not do. You probably have to do more cadaveric work before you're able to do these. Finally, coming to cervical tumors. With lateral mass screws, you can also insert them for myelopathy and cervical tumors. You can approach various pathologies from C1, from the foramen magnum all the way up to the subaxial spine. As an 82-year-old person with a meningioma, with a calcified meningioma, a unilateral approach we have done, and that is what is the post-operative results, and he is doing very well. And a similar patient with severe myelopathy, a foramen magnum meningioma, you can see it extending up and down, and it's also compressing severely the vertebral artery on that side. But we are able to remove this completely, and these are the post-operative images through a small incision. Again, these are not surgeries that you should be doing initially. These are technically challenging through a small corridor, especially around this craniovertebral junction. But it is definitely possible to do them through small tubes, and these patients get discharged in 2 to 3 days' time. So, in summary, motion preservation strategy for unilateral radiculopathy. So these are some of the reasons why it's gaining interest. Patient expectation with keyhole surgery. Why can't this be done when we're able to do so many pathologies in the lumbar spine, the cervical spine being more common or equally common? Why not being able to do these things? There is a lot of literature coming up, though open surgery is fairly very minimal, like an ACDF or an ACDR is minimal. This can still be supplemented with endoscopy, and more people are doing anterior cervical endoscopic discectomies. So the success is patient selection, a technique, a good workflow, and monitoring your results. So the right indication of unilateral pathology is more superior. Facet preservation is possible. Do not compromise on your decompression, because that is what the patient requires. And there is a steep learning curve. And MIS integration with robotics and navigation, which our next speaker is going to talk to us about, has made MIS more attractive. Thank you so much.
Thank you, Bala, for a very excellent overview. So apart from posterior laminoforaminotomy, which is one go-to technique which you will not do open in today's time.
Which I will not do open. So I think that is probably...
Yeah, so I mean, your go-to that, that changed your practice from open to MIS, that you stopped doing open at all for those kind of surgeries.
Yeah.
Apart from, of course, this laminoforaminotomy.
I don't think in the cervical spine I would standardize and use things as I would be using in the lumbar spine, where if you're an endoscopic surgeon, you can do pretty much 90% of all your surgeries in endoscopy. But here it's a very highly patient selection. So as you said, foraminotomy is one thing I would definitely do it through a tube. But yet for myelopathy, no, I'm not going to do for majority of my cases. I recently did last week a patient who had an adjacent segment disease at C2-3. So we had a C3 to C6 fusion, and C2-3 had an adjacent segment disease with a slight translation. So there I used a tube, but I was able to insert a tube. But on a standard basis, I have not changed my practice, because one, the literature is also deficient, and my experience is also not there. And there's not many cadaveric courses or opportunities to be able to put in pedicle screws and learn on cadavers as well at the moment. So I think more anterior cervical discectomy. I don't think I would change my technique, because my incision for a single level would be only 2 centimeters. Maybe it might reduce by half a centimeter. It doesn't make a difference. So in the cervical spine, it is not yet changed significantly. And whatever cases I've shown are very limited, and there's a small number of pathologies that I have done. I don't have the experience like maybe other faculty might have.
So the next question is, you are doing lumbar fairly almost exclusively from tube, if I understand you well.
Yes.
How do you find the difference between tubular cervicals and tubular lumbar?
Yeah. So that's a very good question, because one, in the lumbar spine, you have a lot of muscle mass and bulk to be able to dock your tubes very nicely. In the cervical spine, Yes, for a posterior cervical foraminotomy, you're okay. But if you're going to go further higher up into the cervical spine, docking your tube is a challenge. So I think you have to learn the technique of docking your tube, because you have your patient on pins. You cannot go and yank your tube down, and you cannot push. So you have to dissect the fascia and very gently use a dilator with a hand or something, and then put your tube. So docking the tube is one where you can cause some problems. Second is again the spina the bifid spine as you go into C2 or C3 sometimes does not allow you to dock the tube properly. So this is again another challenge that you might face while placing your tubes through that. So I think with the cervical spine there are some smaller challenges, but apart from that there isn't much.
Okay, great. Thank you, Bala. If there is no questions, maybe we can go to our next speaker, Dr. Vidyadhara, who is head of a department at Manipal Hospitals, and he's going to talk on robotics and navigation in cervical spine surgery. Over to you, Dr. Vidya.
Good evening. Friends, I think, am I visible? My slides are visible?
Yes, Dr. Vidya, it's visible. We just have to start the slideshow.
Yeah.
Okay.
Good afternoon, everybody. Thank you, Dr. Ajoy sir and Dr. Niraj for the invitation to speak at APSS Cervical Spine Summit. I'm Dr. Vidyadhara from Manipal Institute of Robotics Spine Surgery at Bangalore. Today, I'll share how robotics and navigation are helping us convert high-risk cervical fixation into reproducible precision. Cervical pedicle screws offer the strongest fixation in the spine, but they're also the most unforgiving screws to place. Let me begin with a case, a 65-year-old male with a C6-7 fracture dislocation and a complete cord injury. This is a classic 3-column instability where strong fixation is essential. Cervical pedicles are extremely small, about 4 to 5 millimeters, and the vertebral artery lies just millimeters away. Freehand malposition rates have been reported up to 30%. Yet, pedicle screws provide 4 times pull-out strength, making them the ideal anchors in trauma and deformity. So we face a paradox. The strongest fixation is also the most dangerous to place. Robotics improves trajectory accuracy and reproducibility, reducing this variability. So let me briefly show you how this actually works in the operating room. The robotic workflow is simple: scan, plan, and execute. The CT scan taken inside the theater provides the map. The surgeon plans the trajectory in 3 dimensions. The robotic arm guides the instrument along that trajectory, much like GPS navigation for surgery. At our center, we use MasorX Stealth Edition, integrating navigation, robotic guidance, and O-arm imaging. This allows CT-based planning with real-time verification during surgery. Our robotic program started in 2023, and since then we have done more than 1,500 robotic spine surgeries, including over 1,000 cervical pedicle screws. Our workflows and innovations have also been published in peer-reviewed journals. Stability is essential for the robotic accuracy in neck. We developed a pinless mounting technique using the C-flex system of the Mayfield tongs, which are attached to the Allen table. Our published data of 750 cases showed that accuracy is comparable to the traditional pin fixation, and this workflow is now widely adopted across the globe. The workflow begins with the Mayfield head fixation, log roll positioning, robotic docking, and intraoperative CT scanning for navigation registration. Once the registration is complete, we perform the 3D trajectory planning in both sagittal and axial planes. Proper planning also ensures smooth rod alignment and allows multiple screws through limited incisions using skin level feature of the robotic software. On the left side, we are planning the screws, and on the right side, we are planning the skin level feature for getting the maximal screws through a smaller incision. One limitation of early robotics was the lack of cervical specific instrumentation. Only the sleeve dilator and the high-speed Midas-Rex drill are navigable. To overcome this, we developed custom robotic screwdrivers and MIS workflows. A lateral percutaneous incision is made through the robotic arm for the dilator and sleeve placement. followed by pilot hole drilling with a feather touch drill. We initially used guide wires and MIS dilators of the lumbar spine, then developed custom robotic screwdrivers as shown in the second video for Vertex and Atlas also. And this work ultimately led us to the SpineVidya CTech system, which is a Make in India solution for the cervical robotic workflows, with all innovations now being published. These innovations allowed us to evolve a reproducible cervical robotic workflow. Let me now illustrate this workflow with a few representative cases. Returning to the case we saw earlier, a 65-year-old male with C6-7 fracture dislocation, Asia type A cord injury, CT scan showing bifacetal fracture dislocation, a 3-column injury ideally needing front and back surgery. Robotic planning allowed us precise placement of cervicothoracic pedicle screws. And here we go. The posterior construct alone reduced the fracture and restored alignment, allowing us to avoid an anterior surgery. This second patient is a 73-year-old elderly man with an ankylosed spine, having failed lateral mass screws and severe sagittal imbalance. He had progressive forward stoop and chin-brow vertical angle of 45 degrees. Using robotic pedicle screws from C2 to T3, we plan to correct the deformity. Postoperative radiographs showing perfect implant positioning and good correction of deformity from C2 to T3. The CBVA improved from 45 to 22 degrees and a functional forward gaze was restored. This third patient is a 67-year-old lady with Parkinson's plus syndrome with dystonia and drop head syndrome, upper cervicothoracic scoliosis of 17 degrees with head tilt to left side, and a rigid focal cervical kyphosis of 47 degrees. Excellent restoration of coronal and sagittal balance using SpineVidya CTech system from C2 to T4. The CBVA improved from 16 degrees to 0.4 degrees. Orientation of the head and neck before and after surgery in coronal and sagittal planes can be seen here from the above lane and the below lane. This fourth patient is particularly challenging, who is a 13-year-old boy with dystrophic cervicothoracic kyphoscoliosis of 110 degrees in a case of neurofibromatosis. First scan covered from C3 to T5. Few of the cervical pedicles on the convex side were deformed, dysplastic and thinned out, and hence we preferred not to instrument them. The second scan covered from T5 to T12. Postoperative radiographs revealed good restoration of coronal and sagittal balance, and patient was mobilized within 6 hours of surgery. We published this case concluding that robotic planning allows us to select safer trajectories, avoid artery risk zones, and to achieve stronger anchors for deformity correction. Robotics also can complement anterior cervical procedure, like in this patient who is a 64-year-old male presenting to ER with complaints of neck pain and bilateral upper limb weakness following a road traffic accident. First, we did an ACDF at C3-4 in supine position using robotic navigation guidance. Next, cervical pedicle screws were planned, avoiding the anterior screws. This shows percutaneous cervical pedicle screw instrumentation. We placed a small radio-opaque skin marker to periodically verify the navigation accuracy above and below the operative field. The dilator sleeve is positioned first, followed by drilling with a Midas Rex drill, as you are seeing, using a woodpecker technique to prevent skiving. The drill speed is reduced while crossing the pedicle, after which the screw is inserted along the planned trajectory. And here we are seeing the screw being inserted. The navigation doesn't look very accurate because these are custom screwdrivers, not coming with the company. These are intraoperative and postoperative images with perfect implant positioning. Here, another 20-year-old male with a history of road traffic accident and quadriplegia at presentation. MRI showing burst fracture of C7 vertebra with cord edema. Following C7 corpectomy in supine position, under robotic guidance, we planned percutaneous posterior cervical screw instrumentation for a 360-degree fusion. Postoperative X-rays show accurate implantation of posterior tension band with posterior tension band effect, aiding anterior fixation through paramedian incisions on either sides, as you can see here. In our published series of MIS sleeve dilator technique in 65 patients with 565 screws, we achieved 98.76% screw accuracy. Another study of 206 cervical pedicle screws using custom screwdrivers showed 98.1% clinically acceptable accuracy. Average screw insertion time was around 6 minutes with low blood loss and significant functional improvement. After approximately 20 cases, operative time stabilizes while the accuracy advantage remains. The key lessons during execution of minimal invasive cervical pedicle screws. Number one, maintain good rigid motion control. Verify the navigation registration from time to time. Use cervical specific instruments and always keep bailout strategies ready. Cervical fixation is fundamentally a planning dominant operation. Robotics does not replace surgical judgment. It makes execution more reproducible. And when technology and surgical experience work together, patient safety improves. I would like to take a moment to thank my team for all the support and involvement, without which all that I spoke about would not have been possible. And also, I take the opportunity to invite interested surgeons to participate or attend in the Spine Roboticon 2.0 on the 5th and 6th of December 2026, hosted by Manipal Hospital, Old Airport Road, Bangalore. Thank you. Thank you for patiently listening.
Thank you, Dr. Vidya. I have one question that, what are the challenges you have faced in your evolution from open surgeon to robotic cervical pedicle screws, because I think robot is still, in a very early phase, if I understand correctly, as far as cervical pedicle screws are concerned.
Very, very true, Niraj. I think, see, basically, I was never a MIS surgeon. I was a deformity surgeon. And that's why you'll see more of deformities that I've been using the robot for. And in these cases wherein it was nearly impossible to put pedicle screws and to choose the right direction, right? So it has been a big boom. And it was just that we had first started cervical only after finishing 250 lumbar spines. And then after maybe 10 cases of lateral mass, then we ventured into trying to put a drill into the pedicle percutaneously. And initially we were actually opening the midline, seeing the whole of the lateral mass and then putting under, like my counterpart is going to see where the drill is, whether it's in the right place, whether the entry point is accurate or not. And over a period of time, and it's only after 100 cases that we have started doing percutaneous without opening the midline. And this has been a long journey. I am sure we are going to experience more, exciting moments in the future. And I'm sure we are going to innovate much more things that can be used with the robot and explore newer areas like maybe C1, C2 or occipitocervical, which we have tried. And we have even tried odontoid screws, but there are some technical challenges and I cannot say that they are the best at the moment. But I think in the time to come, there are a lot of fixed ideas that we need to first fix ourselves with and try with safety. Once you do a minimum number of surgeries, gain confidence and make sure that you have a 3D orientation of the whole place before you even drill anything. I think that is the most important. It's not for a beginner to start percutaneous robotic cervical pedicle screws. That much I can be very sure. I hope I have answered.
Thank you. Thank you, Doctor. So before we go to Dr. Reuben, he has a question. I just want to have a follow-up question. I know Dr. Vidya is a strong proponent of robotic, but I would want to ask all the panelists here, 3D navigation or robotic in cervical, what scores better and why? I know your answer, Dr. Vidya, so I think I would skip you. You know that you still you are doing robotics, probably one of the highest number in our country. So I guess maybe Dr. Ajoy, Dr. Reuben, Dr. Professor Yoshiharu, Dr. Lee, anybody can just take on the question: 3D navigation versus robotics.
No, I would also tell that I have no experience with 3D navigation, so that's my
Okay.
confession also.
Okay.
Thank you.
Dr. Reuben, maybe you can answer the question, this question, and then you can ask your own question.
Yeah, I will answer that as saying that I use 3D navigation fairly quite a lot, and so I think that's quite helpful. When I had the robot in my hospital, I hadn't explored cervical robotics, and so I don't think I can speak for cervical robotics at this stage. My question actually for Dr. Vidya is really the cervical spine is very mobile. And so even when we are doing 3D navigation, we are having a lot of fixation challenges. It keeps moving. And so how do you ensure that you are not off the navigation when it comes to doing the robotics? Because now you're even more MIS, you're seeing even less. What are you using as a reference frame to continue to check that you're still correct and accurate?
Yeah, there are 2-3 things we are violating. One is we are not using the pin, which is recommended, or the spinous process clamp the company recommends. And that we have proved beyond reasonable doubt in thoracolumbar spine that it doesn't matter. Actually, the accuracy remains the same. The second one is you have the mobile cervical spine, but what our experience has been that if you fix it with the C-flex attachment of the Mayfield tongs to the Allen table and strap the patient tightly with plasters all around their shoulders, that gives literally, like I have seen even patients bucking and the registration, the navigation accuracy not changing. Secondly, we also, to add to the safety, above and below, like nearly at C2 and C7, we put a radio opaque markers, which I have shown in the video actually, which are like a cross. And we keep checking, putting the chicken foot there and checking whether it's accurate or not from time to time, but not off late, like unless you see that, okay, you are putting your sleeve dilator and you see that it's off, you put it there and check whether it's still accurate or not. If it is not, we are not going to go ahead with the drilling.
And when it's off, what do you do? Do you scan again or do you change?
We can do a snapshot again. Most of the time things settle. It may be just a flaw with the software. And if it is not, even after snapshot, you'll have to respin.
Thank you.
But we had very few cases of respin. Ajay sir.
No comment. I mean, as Vidya said, you have to believe and do it. It's just that if you keep doing it, it will become more and more accurate. I mean, we have used robotic for cervical spine, but not so much. I mean, I have used a lot of navigated screws, but you need to be bolder like Vidya to move ahead and to start using robotics at that level. But once you do it, you keep doing it, probably he has understood all the fallacies of it, and now the results are better.
Absolutely. I think there is a lot of learning curve, and I think not to hurry is the only key. I think every time you lose accuracy, please don't drill, no matter who you are. I don't think even after 100, I don't have the courage to drill if it is not accurate on the sleeve dilator. And the other thing is, definitely everything is done under neuro monitoring, so we don't venture out something, and we don't stimulate after the scan and before all these implants are put in, because again, repeated stimulation can change the accuracy. So, but we don't fix it. The pin or the spinous process clamp we are not using, because that itself can cause a lot of problems, because the clamp moves and your whole registration is lost. I think Professor Yoshiharu is having some question.
Thank you very much. My question is very similar to Reuben. And I'm a robotic user, but I only applied the thoracolumbar, not the cervical. So my question is very simple. Do you use images during surgery if you use robotic surgery?
Pardon?
Image.
No,
Do
no
you use
image intensifier
no image at all?
at all.
Thank you.
I
Yeah.
think you should visit us for the Roboticon 2.0. We had last time 2024, wherein I think Dr. Ajay sir has seen, we have demonstrated the first time cervical live cervical pedicle screws, and this year again we are going to showcase the cervical, but this time it is percutaneous.
If you
You're most
apply
welcome to
the if you apply the lung fusion from cervical to thoracic, you divided two legislations.
No, actually, in the cervical, we are able to get from C3 to T2 or T3. In one patient, we got even C3 to T4. Depends on the height of the patient. If it is a tall fellow like that cervicothoracic scoliosis, I had to use 2 spins. Even there, C3 to T4 was 1 spin and T5 to T12 was the second spin. He was 6 foot 2 inches.
Yeah. If you will fix from C2 to T4, the long distance from the registration might be not accurate, I'm afraid.
No. No, not at all. The only problem is if you retract the skin, if there is a soft tissue pressure, then there is a risk of skiving. And secondly, we always do that woodpecker technique. Touch, touch, touch and go. It is not like go on drilling. And as you approach the difficult areas like near the vertebral artery foramen, you reduce the speed and go at maybe 15,000 RPM, 25,000 RPM, not 75,000 RPM. I think that has really helped us gain more confidence and more faith in the robotics.
Thank you very much.
Thank you, sir.
Niraj, you
Thank
should.
you. Thank you. I guess, no, sir, it's a chairman's privilege to conclude the session, your summary statement and conclusions.
I think, Niraj, you can do that. It's fine. Thank you.
Thank you, Chairperson. Thank you all the faculties for an extensive discussion on cervical spine. We have started covering everything right from imaging to sagittal parameters to anterior procedures to posterior procedures, disc replacement. Then we touched upon MIS and finally technologically heavy robotic spine surgery. So I guess, the delegates and viewers have actually got the scenario where the cervical spine surgery stands today. In fact, I learned enormously from this session. I thank APSS Secretariat for setting up all this mammoth task, and also would want to thank OrthoTV for providing us the online platform to host such kind of webinar. I would also want to name my two colleagues, Dr. John and Dr. Guna, for helping me out with this organizing this webinar. Thank you, everybody, and have a safe Sunday. Have a nice Sunday. Thank you so much. I'm declaring this webinar closed. Thank you so much.
Thank you.
Thank you, Niraj.
Thank you, Niraj.
Thank you. Thank you. Thank you. Bye-bye. Bye-bye.
Thank you, Niraj. Thank you. Bye-bye.
Bye-bye. Bye-bye. See you soon.